2017 epidemic is just over. The maximum number of patients in Kerala of all dengue epidemics was in 2017. Huge number. So dengue fever management must be familiar with every patient, every doctor. Everybody knows it is a mosquito-borne disease and it is rapidly spreading and amounting to global epidemic, including India, Kerala. And the number estimated is about 50 million infections globally. And the most disappointing fact is majority occur below the age of 15 years. The global mortality, which is described in the literature, is about 3 to 5%. But we know many parts of the world, the care is not very much adequate. But if you look at the Kerala data, the mortality is definitely less than 1%. So if with good treatment, you can reduce the mortality to less than 1%. So that is a Kerala data from 2013 to 2017. And you find the mortality is less than 5% all these years. 2013, 14, 15, 16 and 17, mortality in Kerala was less than 0.5%. It's very encouraging to note that we have reached a good standard of health care thanks to all the doctors practicing in the various aspects. You find the maximum number is in 2017. After 2013, the maximum number of epidemics. Now this is some of the paper cuttings. You find most of the things, it is pani, maranam, that is the way it is. So this has got a very great impact on the profession as well as public. What is the positive aspect? Public awareness is increased. And when a lot of things are coming into media, the government and administration is also alerted. They will take action to prevent and effective treatment. Medicines will be made available. But it has got a very negative aspect also. The majority of the press project on death. You find Pani Maranam, Dengue Maranam. They won't say that 1,000 people were admitted in a hospital and 999 cured and went home. They will say 1,000 admitted, one person died, and the photo of the person is also presented in the media. So that is the one. And creating fear among the public. What is the consequence of that? Even uncomplicated, simple problems are referred to secondary or tertiary care center, leading to overcrowding, and especially in the government hospitals, overcrowding. Naturally, quality of care of other patients will also come in. And definitely, from a remote area, patient going to government medical college or district hospital, general hospital, or private hospitals, about more than 60% of the health care in Kerala is private. So cost of treatment tremendously increasing. That is the negative aspect. Now coming to the topic proper, the vector, it is Aedes aegypti primary, followed by Aedes albopicus also. Virus also, you're all familiar, RNA virus. There are 4 serotypes. No need of remembering 1, 2, 3, 4, so easy to remember. And it's known that serotype 2 and 3 generally associated with severe disease. The word about immunity after infection is long-lived or even lifelong for that specific serotype. And a short-lived immunity, cross-immunity for the other types. And it disappears. So sequential infection can occur. Theoretically, an individual can get dengue fever 4 times if our serotypes are present in the data. Now, word about reinfection. After the first infection, IgG antibodies are present for a long time, indefinitely. And when you have a second infection by another serotype, there is a phenomenon of antibody-dependent enhanced virus multiplication. When large number of virus there, large infected cell mass occurs. And this leads to exaggerated immune response leading to organ dysfunction or organ damage. In fact, organ damage is not directly caused by virus, but it is produced by the immune mechanisms. So an exaggerated immune mechanism is responsible for the more serious presentation of reinfection. Now, risk factors for severe disease are very young, especially infancy. Female 6, little more than that. High BMI is obesity. Virus 2 and 3 I have already remarked. high early viremia as evidenced by high NS1 antigen titer, reinfection already mentioned, and of course any disease severity genetic makeup of the individual, and in pregnancy also that may be a little more serious. Incubation period is average is 5 to 7 days, but it can be as long as 14 days. Natural history, I think any practicing physician must know the natural history disease. When an individual is infected with the dengue virus, the outcome can be four. One is subclinical infection. Infection occurs but no symptoms. Very common. Many viral infections. Not only dengue, many viral infections, that is the sequence. Second is a good percentage of people develop a very simple fever without any classical manifestations of dengue. So we call it as a simple, short-lived, undifferentiated fever. Unless you look for the serology or you will not diagnose. And the third is the classical dengue fever syndrome. It can occur with warning sign or without warning signs. And the fourth entity is a little complication, which we call it as the severe dengue. I think this is the simplest classification. We have the other previous classification, dengue hemorrhagic fever with the so many types, dengue shock syndrome and all. That is difficult to remember, difficult to practice. This is easier. So we have classical dengue fever and the severe dengue fever. Very easy to remember, very easy to practice also. A classical dengue fever features are an acute febrile illness, usually lasting for 2 to 7 days, associated with headache, retroorbital pain, severe myalgia, arthralgia, and bone pain, and hence the term breakbone fever. A transient erythematous macular or maculopapular rash is commonly seen, and a flushed appearance is very common with congested eyes, red lips, and in a minority, a rash may reappear also. Petechiae may be seen, ecchymosis may be seen in minority, and tourniquet test is often positive. And what is tourniquet test? Very simple. Apply BP cough to the apron. Raise pressure in the cough between systolic and diastolic and keep for 5 minutes. Mark an area of 1 square inch, that is 2.5 square centimeters. If you have more than 10 petechiae, we can say it is positive, and more than 20, it is definitely positive. Just like Manto. 5 more and more, it is just positive, more than 10 is definitely positive. So here also more than 10 is positive and more than 20 petechiae is definitely positive. Already mentioned about the classical dengue with warning sign and without warning sign. So what are the warning signs? Very important, especially for practicing physicians. Severe mild abdominal pain may not be there. Severe abdominal pain and abdominal tenderness. Persistent vomiting. Vomiting once or twice may not be important. Clinical fluid accumulation, especially in the serous cavities, pleural effusion and ascites, either clinically or by ultrasound. Mucosal bleeding. 1 or 2 petechiae is not warning sign. Present significant mucosal bleed. Lethargy and restlessness. Liver enlargement more than 2 centimeters, not clinically very significant. It is, as per literature, it is there, but not very useful. Increase in hematocrit more than 20% with a rapid reduction in the platelet count. So these are the warning signs. Importance is, we will again discuss. And severe dengue, we have 3 parameters. One is severe plasma leakage. This usually occurs as the fever disappears, not during the fever. Second is severe hemorrhage, significant hemorrhage, producing a fall in BP and fall in hematocrit. And third is severe organ dysfunction, manifested by 1 transaminase increase more than 1000. CNS involvement with altered sensorium, restlessness, or seizure. Myocarditis with arrhythmias or cardiac failure. Renal dysfunction with renal failure. And lung involvement even amounting to ARDS. So those are the manifestations of severe dengue occurring in less than 5% only. Plasma leakage is actually the most important aspect deciding the prognosis and not thrombocytopenia. And severe plasma leakage usually occurs between 3 and 7 days after the onset of fever, presenting with 1 hypovolemic shock. Respiratory distress due to fluid accumulation either in the lung or in the pleural cavity. An increase in hematocrit more than 20% from the baseline. indicating that hemoconcentration has occurred, plasma has escaped. Pleural effusion, ascites, and edema. Hypoalbuminemia, because capillary permeability is increased, albumin also escape. Normally, albumin do not escape. And capillary permeability increase in the renal glomerulus, naturally it produces proteinuria. So these are features of significant plasma leakage, and that is the most important point which will decide the prognosis, and not thrombocytopenia. Hypovolemic shock, clinical features, everybody knows: tachycardia, cold, clammy extremities, weak or undetectable pulse, hypotension in adult defined as less than 90 millimeters systolic BP, narrow pulse pressure, and evidence of tissue underperfusion. Organ damage, another important aspect which has been observed is, in some cases, multiple organ damage occur in a small percentage. It can occur even without bleeding or shock. That is immune mediated, cytokines and others. Bleeding in dengue hemorrhage fever term has been there. The causes are two. One, thrombocytopenia. Only when it is severe, when it is less than 10% severe bleeding occurs. Second is, in a small percentage, you have coagulopathy. Due to multiple reasons, no intention to go into the pathogenesis of that, but it is a fact. And how to detect that? Clotting time is prolonged, and APTT is also prolonged. And APTT, when it is prolonged, one of the simple things which you can do, even in the primary setup, is what you call mixing study. Mixing study is very simple. You take the patient's plasma, mix with the normal plasma, and repeat the APTT. If it is corrected, it means the coagulopathy is due to defect in the clotting factors. So the treatment, it has got implication. We will come to that. So that is about the clinical aspects. The most important is diagnosis followed by treatment. Diagnosis of any disease, it is clinical followed by lab. And lab, especially infections, we have supportive evidence and specific evidence. Supportive lab will be, clinical we have already discussed. Supportive will be leukopenia. If you closely observe, actually leukopenia occurs much earlier than thrombocytopenia. The first thing, even second day you do leukopenia. Thrombocytopenia may occur on the fourth day or fifth day. Thrombocytopenia is present in the vast majority. Low serum albumin because of capillary leak. Proteinuria because of increased capillary permeability. SGOT, SGPT is variable. Usually, it is almost always elevated, usually in the range of 2 to 5 times the upper limit of normal. But in severe dengue, it can be 10 to 15 times or even larger. We have seen cases of 2,000, 3,000 SGOT, SGPT in severe dengue. X-ray test is optional, need not be done in all. When you suspect pleural effusion, lung involvement, okay. USG abdomen ultrasound, again optional. When you suspect complication, ascites. APTT is again optional if bleeding manifestation is present to confirm that there may be associated coagulopathy. Hematocrit is mandatory. Every patient you have to do. How often we will come to that. Hematocrit, more 20% increase from the baseline is indicating significant plasma leakage. And it can be corrected by sufficient intravenous fluid, and the fluid of choice is either normal saline or ringulated. Sometimes you get a decrease in hematocrit that indicates significant bleeding requiring blood transfusion. Now we come to the specific diagnostic test. It is very simple. First 5 days is a viremic phase of dengue fever. And any infection, the gold standard of diagnosis is, whenever possible, isolate the organism. For example, urine culture. Urinary tract infection, you do the urine culture and demonstrate the E. coli or other organisms. Pulmonary tuberculosis, you demonstrate the acid fast bacilli in the sputum. So same thing is applicable here also. Whenever possible, demonstrate the organism. But virus isolation, is not very easy, and it is not done also commonly. Next thing is you demonstrate the antigen of the organism. Antigen. So in dengue, you have the NS1 antigen. And it must be done by ELISA method and not the rapid diagnostic kit method. That is unreliable, very low specificity and very low sensitivity. So you can get false positive, false negative. And the WHO recommendation, National Vector-Borne Disease Control recommendation is don't do the rapid diagnostic test. Either you do the test or don't do the test. If you do the test, ask for an ELISA. There is a minimal change in price only. So it is all these tests must be ELISA based and not the rapid diagnostic test. So NS1 antigen by ELISA is confirmatory. It is indicating viremia, indirect. Next thing is you can demonstrate the nucleic acid of the virus, RNA, by PCR. Again, it is theory dominantly because it is limited to very few centers. So routine practice, you don't have RNA, the PCR for RNA, you don't have viral culture. So you have the first 5 days practically coming back, the diagnostic test is NS1 antigen by ELISA method. Now, none of the other things are practically useful. Now after 5 days, what do you do? Antibody response occurs. And we know any infection, the first antibody that appears is IgM. So you do the IgM antibodies after 5 days by ELISA and not by rapid diagnostic test. And the IgM antibodies usually become positive after 5 to 6 days, peak in 2 weeks, and after about 2 to 3 months, it comes down and disappears. Secondary infection, that is already patient had dengue in the past by another serotype, this IgM response may be low. Instead, you may get an IgG response. But if the IgM response is negative initially, antibody, the basic principle is rise in titer. So you can repeat the IgM if clinically suspected after preferably 10 to 14 days. So initially IgM negative by ELISA, after 10 days it becomes definitely positive, confirmatory diagnosis of dengue fever. Single high titer is also diagnosing. What about IgG antibodies? In primary infection, it appears late and persists infinitely. So rise in IgG titer amounting to fourfold increase in IgG titer is also diagnostic. Secondary infection, IgG rise occurs more than IgM. So IgG is important especially in secondary infection. IgM response may be low, but IgG response will be fast. So a fourfold increase in IgG is confirmatory of dengue fever. Initial IgG is low and more than fourfold confirms the diagnosis. Now, there are two terms which are used. Even in that slide where Kerala, I had shown the presumptive diagnosis and the confirmed diagnosis. So one is a presumptive diagnosis of dengue fever, an acute febrile illness, 2 to 5 days with any two of the following, 2 or more. Anorexia, nausea, rash, aches and pains, warning signs, leukopenia, positive to only get test, plus a non-ELISA based NS1 antigen or IgM antibody. So with this you can only say it is a probable or presumptive diagnosis of dengue. And confirmed NF fever is, dengue fever is compatible clinical picture plus at least one of the following. Isolation of dengue virus, practically not useful. Demonstration of virus by RNA only in selected centers. But the most useful will be NS1 antigen positivity by ELISA. IgM antibody by ELISA. IgG zero conversion by ELISA, more than 4-fold rise. It's a repetition of what I have said in the previous one. So that is the confirmatory test and it's available in many laboratories in Kerala, even in the periphery. Only thing, government setup, it may not be present always. But people willing to do it, you can get it done from outside using ELISA. Write ELISA, IgM dengue ELISA, IgG dengue ELISA, NS1 antigen ELISA. Unless you write that, I will do the rapid test which you can get in 15 or 20 minutes. Now how to monitor the patient in the management? Temperature has been recorded, intake output chart because hypotension can produce problems. Pulse and BP must be periodically monitored. Recording a BP must be very, very careful because pulse pressure is very important criteria. So unless you record very carefully, you may miss. Watch for bleeding, especially from the nose, gum, skin, vagina. Look for hematemesis, hematuria, and bleeding from the venipuncture site. Level of consciousness to be assessed because a small percentage can go into complications, encephalitis and seizure. Dyspnea is important because of fluid accumulation either in the lung or pleural cavity. Abdominal pain and vomiting persisting, it is again indicating that patient may develop complications. A word about blood pressure, I have already cautioned that it must be recorded very carefully. Just mentioning, all the values are applicable to adults. Patient X is having a blood pressure of 100 by 85 and patient Y is having a blood pressure of 90 by 60. Any guess which is better? X or Y? The answer is definitely 90 by 60 is definitely better than 100 by, what was the previous value? 100 by 85. So here, what is the pulse pressure in 100 by 85? Only 15 millimeters. What is pulse pressure? It is a reflection of the stroke output. Now it is reflection of the cardiac output. So pulse pressure reflects cardiac output if there is no arterial change. If the artery is behaving normally, pulse pressure is a reflection of the cardiac output. In the first case, it is only 15. Lower normal is 30. Whereas, what is the second case? 90 by 60, it is 30. So it is in the normal range actually. So that indicates near normal cardiac outputs. So that's why I said blood pressure in dengue is important. In pulse pressure, look at the blood pressure. It narrow pulse pressure indicates the low cardiac output. It might indicate either bleeding or capillary leak. Lab monitoring, platelet count daily, hourly platelet count not necessary. Hematocrit daily or occasionally as more frequently as indicated, we'll come to that. APTT when indicated, serum albumin when indicated, SGOT, SGPT, of course, very frequent monitoring is not necessary. Maybe once in 3 days, 4 days is okay. Coming to treatment proper, therapy proper, all viral infections, we know it is treatment with a few exceptions. Treatment is symptomatic and supportive. There are exceptions like HIV, chronic hepatitis B and C. There are exceptions, chickenpox. Those virus infections, you get a specific treatment. But dengue fever treatment is dominantly symptomatic and supportive. And for fever and pain, use only paracetamol. Food according to desire and appetite of the patient and not according to fancy of the doctor and the relatives. Adequate oral fluids, 2.5 to 5 liters per day depending upon the situation. Most important, if you remember only one slide during this presentation, this is the most important slide. What not to do in dengue fever. No aspirin, no NSAID. No steroids, no antibiotics. No IV fluid if oral is well tolerated. No bleeding, no hypotension. No blood or platelet transfusion unless absolutely indicated. Why not aspirin? Aspirin has got antiplatelet effect. Dengue fever, thrombocytopenia occurs in the vast majority. Aspirin can produce gastritis, including erosive gastritis or hemorrhagic gastritis. And when there is thrombocytopenia and coagulopathy, the bleeding can be very severe, it can be even fatal. So aspirin is contraindicated. And pediatric, it can produce Reye syndrome also. Why NSAID is contraindicated? Severe gastritis is a common side effect of NSAID. It could be erosive or hemorrhagic leading to hematemesis. And with thrombocytopenia, coagulopathy, hematemesis can be very severe and life-threatening. It has got antiplatelet effect too. Nephrotoxicity is one of the most important side effects of NSAID. And dengue fever, renal dysfunction is one other thing which is described in men. Hepatotoxicity to some extent also described in dengue fever. And liver involvement is universal in dengue fever, mild liver involvement. It may be aggravated by NSAID. And steroids, no benefit, side effects are there. It will increase the cost and therefore not recommended. Antibiotics, no benefit. Secondary bacterial infection is a reason which is projected by people using it. It is extremely rare. When it occurs, use it, not in every patient. It has got side effects. It increases cost of treatment and therefore recommendation is antibiotics should not be used in dengue fever. When will you give IV fluids? Persistent vomiting leading to dehydration. Significant capillary leak leading to hypovolemia and hypotension. Significant hemorrhage. Start initially and replace with the packed cell or occasionally whole blood. IV fluid, the most important indication is when there is capillary leak, plasma leakage. This usually persists only for 24 to 48 hours, usually towards the end of the fever. So, most important parameter to monitor is a hematocrit. When plasma leaks, hematocrit naturally increases. VCV and hematocrit increase. Fluid must be just sufficient to maintain effective circulation. It is mainly a clinical fluid. So, how to decide on adequacy of fluid? It's a clinical judgment mainly. Look at the pulse, blood pressure, and urine output. Urine output 1000 means the fluid is reasonably adequate. Hematocrit is other guideline. Look for development of lung signs, especially crups in the lung bases. It might indicate development of. Look for pleural effusion. So be careful with IV fluid also. Excess IV fluid, if you give, it can lead to large pleural effusion, large ascites, pulmonary congestion, and even pulmonary edema. So IV fluid is a double-edged sword. It is life-saving on one side, and when you use it injudiciously, very liberally without monitoring, it can also be fatal. Platelet transfusion, the absolute indication is less than 10,000. When it is less than 20,000, more than 10,000, optional. If there is bleeding, you can give it. Otherwise, not in. Platelet count 15,000, 14,000, not a definite indication. Will you use fresh frozen plasma? We already discussed. Coagulopathy can occur in a minority, and APTT prolonged and corrected by mixing studies indicating there is a coagulation factor defect, which is probably lost. So it to be corrected by giving fresh frozen. So indication for fresh frozen plasma is coagulopathy with prolonged APTT corrected by mixing study. Factor transfusion when you give simple major bleed. Sufficient to produce hypotension and fall in hematocrit. Usually it rise in hematocrit. Fall in hematocrit, hypotension, we will give Paxil. This is a golden rule. No blood or blood product is absolutely safe, even if you do the screening. Most of the screening tests are only rapid tests. They are not foolproof. And you know the window period of many things. So hepatitis B, hepatitis C, HIV, and so on. Now, next question is where to treat? At home, primary care, secondary care, or tertiary care? What is the answer? Can you get treated home? Definitely yes. You have a group of patients which you can call this group A. Uncomplicated dengue fever, no warning signs, no organ dysfunction, no hypotension. They can be treated at home with the paracetamol, sufficient oral fluids. Daily review for disease progression is important. And strict instructions must be given to come to the hospital if any warning signs. They must be taught what are the warning signs and it appear. What about group B? Group B is dengue fever with warning signs which you have discussed. They can be treated in the secondary care center. And other in the infancy, old age, and pregnancy, complication rate may be more, better to admit. Diabetes mellitus, renal failure, chronic hemolytic disease. Again, complication rate has been higher, better to admit. Patient living alone, far away, especially elderly in this nuclear family era, it is very common. So they may not be able to come at the midnight when complication occurs. So it is better to, they have to be monitored very closely. And group B, not very important in the primary care center. You can do the baseline hematocrit, monitor hematocrit frequently, and you can start IV fluid, either normal saline or ringer lactate. If vomiting alone is the feature, ringer lactate is better avoided. Reason is also obvious. Vomiting means you are losing hydrogen ions. That means it will lead to metabolic alkalosis. Ringer lactate, you know, it contains lactate which will be converted into bicarbonate in the liver. So vomiting alone, fluid of choice is not ringer lactate, it is normal saline. If it is plasma leakage leading to hypotension, fluid of choice is normal saline or ringer lactate. Pure vomiting, repeated vomiting, normal saline, not ringer lactate. So these are guidelines only, how to give, whether it is 5 to 7 ml per kg or like that. It is mainly decided by clinical judgments, which we have already discussed. Group C is severe dengue, not very much important, especially people working in primary care and secondary care center. It has to be treated in a tertiary care center, preferably in the ICU. So here IV fluid, little higher rate, 10 ml per kg per hour per 1 hour and all. So this is again guidelines which is available in the all literature also. Here the hematocrit has been monitored frequently, 6 to 8 hourly hematocrit, not daily. When it is shock, again, IV fluid has to be more vigorous. So from the primary care level, secondary care center, message is refer these patients and not treat. You cannot treat in the primary and secondary care severe dengue fever shock because the inadequate treatment will lead to mortality. Now this is important. Even uncomplicated dengue fever, initially appearing uncomplicated, observe for at least 2 days after the fever subsides. I have mentioned few times that usually the capillary leak and complication occurs after fever subsiding. Severe thrombocytopenia, hypotension, capillary leak occurs after fever disappears. So minimum observe for 2 days after fever disappears. If no problem, can be safe. Otherwise, that is the what you call the critical stage. After the febrile stage, critical stage, convalescent stage. Critical stage is development of capillary leak and severe thrombocytopenia, sometimes with bleeding. When you discharge, no fever for 48 hours without antibiotics, return of appetite, visible clinical improvement in all aspects, good urine output, no respiratory distress, and minimum 3 days after recovery from a patient with shock, only in the minority. Mortality, global mortality mentioned in the literature is 3 to 5%, with adequate treatment less than 1%. If you look at the Kerala epidemic, starting from 2013 to 2017, the mortality was less than 0.5%. How to prevent? You know better than me. Control of mosquitoes, prevent mosquito bite, break the cycle of human mosquito infection, and a live attenuated tetravalent vaccine is manufactured by Sanofi Aventis, not available in India now. It is being tried. Let us wait and see how it is effective and how we can prevent dengue fever, just like smallpox in future.